For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Big news, cardio nerds! AHA Scientific Sessions 2025 is now 4 full days. Get more late-breaking science, immersive learning, and meaningful connections. Don't miss core cardiology programming, 21 education communities, and guideline-focused sessions. November 7th through 10th in New Orleans. Register now at scientificsessions.org.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, cardio nerds. This is Jenna Skowronski, chair of the CardioNerds Heart Failure Council. We are so excited to kick off our Advanced Heart Failure series today. Over the course of 7 episodes, we'll take a deep dive into the world of advanced therapies, starting from evaluation and medical workup to perioperative and postoperative management of transplant and LVAD, as well as the essential role of palliative care in these patients. In today's episode, we start our journey by exploring the initial evaluation of advanced therapies. Kicking us off is my co-chair of the series, Dr. Shazli Khan. Shazli is a native Midwesterner who now finds herself on the East Coast as a general cardiology fellow at New York Medical College, Westchester Medical Center. She will be pursuing fellowship in advanced heart failure and transplant cardiology at Columbia. Welcome back to Cardio Nerds, Shazli.
Thank you so much, Jenna. I'm so excited to be here and to help co-chair this awesome series. I'm thrilled to introduce the lead for this episode, Dr. Jason Feinman. Jason is an advanced heart failure and transplant cardiology fellow at Mount Sinai Hospital, New York City. He was first introduced to the CardioNerds group through the CardioNerds Fit Clinical Trials Network by Dr. Anu Lala. He is passionate about all things heart failure and hemodynamics.
Thanks, Shazli. We're so grateful to be joined today by Dr. Michelle Kittleson from Cedars-Sinai, where she serves as Professor of Medicine and Director of Education in Heart Failure and Transplantation. She received her undergraduate degree from Harvard and her medical degree from Yale, and then completed her residency at Brigham and Women's Hospital, followed by her cardiology fellowship at Johns Hopkins. Dr. Kittleson is an author, educator, and leader in the field of advanced heart failure and transplantation, and we hope that she can honor us with some of her famous Kittleson rules during this episode.
Thank you so much. I'm so delighted to be here. Go Cardio Nerd.
Thank you so much, Dr. Kittleson. We're so excited to have you. And with that, let's get started by discussing an awesome case today. So we have a 54-year-old woman who presents for follow-up for heart failure with reduced ejection fraction. She was first diagnosed 15 years previously following an admission for shortness of breath, where an echocardiogram demonstrated a left ventricular ejection fraction of 23%. Her EKG demonstrated normal sinus rhythm with a left bundle branch block and a QRS of 157 milliseconds. Her angiogram at that time demonstrated no obstructive coronary artery disease, and she was started on guideline-directed medical therapy, including carvedilol, lisinopril, and spironolactone. She subsequently underwent a CRT-D placement. She has since been transitioned to sacubitril valsartan, and empagliflozin has been added. Unfortunately, she's still been hospitalized twice in the past year for heart failure exacerbations, despite increasing dosages of her diuretics, and have had to have her sacubitril valsartan discontinued due to lower blood pressure. So Dr. Kittleson, what are the notable features in this patient's presentation that make you concerned for an advanced cardiomyopathy? And what studies might you obtain today that would help to risk stratify her in the outpatient setting?
Thank you so much. What a great case. First, let's highlight the fact that in a way, this is a triumph of modern medicine. She was diagnosed 15 years ago with a non-ischemic cardiomyopathy, so she had a pretty good run. But we can say that there's certainly very concerning features. Every disease has a rhythm and a trajectory, and the longer you live in medicine, the more you become attuned unconsciously to them. But you shouldn't have to rely on decades of experience to get that pit in your stomach. We have the I need help mnemonic, which is really helpful to encapsulate the notable features that indicate that slippery slope of a worsening prognosis. She has hospitalizations. She has intolerance of guideline-directed medical therapy. She has worsening symptoms. These are hugely concerning red flags. And when someone is not doing well, the first question you want to ask yourself is, well, did I miss something? Could I make something better? But she already has CRTD. She's already been attempted to be optimized on the 4 pillars. So those are the concerning factors to me. You can't optimize GDMT because she doesn't tolerate due to hypotension, and she's being hospitalized. Huge red flag, sentinel event. So as an outpatient, I like to do a cardiopulmonary exercise stress test as an objective confirmation of her decreased functional capacity. As we know, the maximal oxygen consumption less than anywhere between 10 to 14 milliliters per kilogram per minute and or less than 50% predicted is very concerning for poor prognosis. The other things I would like to obtain would be a comprehensive metabolic panel because evidence of end organ dysfunction, kidney, liver abnormalities are suggestive that she is also doing worse.
Thank you so much, Dr. Kittleson. I think that's very, very helpful because I think we see a lot of these patients in our clinics as well. And it's important for everyone to hear what some of those red flags are that tend to come up that make our alarm bells start going off and when we should start thinking that maybe this is someone who would benefit from advanced therapies. So following all of your testing, she's admitted to your hospital with concern for an advanced cardiomyopathy and the potential need for advanced therapies. Transthoracic echocardiogram on admission demonstrates biventricular dysfunction. She has a spherically remodeled left ventricle and an estimated left ventricular ejection fraction of 14% and a left ventricular end diastolic dimension of 6.7 centimeters. Her right ventricle is reported as being moderately dysfunctional, and there is at least moderate to severe mitral regurgitation. A right heart catheterization is obtained, and we demonstrate an RA pressure of 17, a PA of 65/32 with a pulmonary capillary wedge pressure of 27. We have a measured cardiac output of 2.7 and an index of 1.7. And her blood pressure at the time is measured at 94/48 millimeters of mercury. Based on all this data, what would be your next steps in managing this patient?
Okay, so this is very helpful, and it is not a medical mystery. The patient has been feeling horrible because her heart is terrible. The echocardiogram confirms that, and on right heart catheterization, she is wet and cold, elevated filling pressures, and reduced cardiac index. So let's talk about first what I would not do, and that is to rush her to the cath lab for transcatheter edge-to-edge repair of her mitral valve. Yes, she has moderate to severe mitral regurgitation, but she does not meet the criteria of the COAPT trial or the valve guidelines in that her moderate to severe MR has not been measured after optimization. So I'm putting that aside for a second because the mitral regurgitation is a dynamic lesion that can improve with optimization of volume status and cardiac output and afterload. Again, instead, I'm going to turn my attention to this wet and cold physiology. I'm going to start with diuretics. Maybe a bolus of loop diuretic, but more likely an infusion because that gets the job done. My tool is my diuretic. My goal is an RA less than 10 and a PAD at least less than 20 to push her in the right direction. If I'm lucky, just improving her filling pressures will improve her cardiac output, but I'm probably not going to be lucky. And until the cardiac output goes up, the diuretics aren't going to get to the kidneys. So she's likely going to need a bit of an inotrope to boost her and get this process moving along. Now, my choice of inotropes are dobutamine, dopamine, or milrinone. Let's focus on dobutamine and milrinone as the most common tools to achieve our goal of an index above 2. Now, they're both functionally beta agonists. Of course, milrinone acts downstream of the beta receptor, but think of them both as functional beta agonists. Dobutamine more beta 1 than beta 2, milrinone more beta 2 than beta 1. So what does that mean? Milrinone is more likely to make you hypotensive. Dobutamine is more likely to make you tachycardic. So if my patient is a little more tachycardia with a good blood pressure, I'll pick milrinone. If there's a little bit more hypotension, not that much tachycardia, I'll pick dobutamine. But remember, patients don't read textbooks, so always pivot based on your tools, diuretics and inotropes, and your goals, filling pressures and cardiac index.
Thanks so much for all of that. Just like you said, that's exactly what we ended up doing for this patient. We ended up trialing her on increased dosage of loop diuretics, but unfortunately she did have insufficient urine output, and ultimately we started her on a milrinone infusion. After 5 days of therapy, she had lost approximately 10 kilos, but we obtained a repeat right heart catheterization, and now we have an RA of 8, a PA of 43/22, a pulmonary capillary wedge pressure of 20, but a cardiac output still of only 3.8 with an index of 2.1 while on the milrinone infusion and after volume optimization. Her creatinine has improved slightly to 1.3, and her blood pressure remains at 92/50. Given her persistent low output despite inotropes, recurrent hospitalizations, you believe really that advanced therapies are indicated in her case, and you refer her to your team for further consideration. At this point, she has many questions on who is a part of the team, who will be involved in her care moving forward. How do you explain to patients who will be a part of their evaluation and what additional laboratory studies, imaging, and consults are needed?
So, first, kudos to the team taking care of this patient. Really, this is a fantastic job. 10 kilos is very respectable. Her hemodynamics have gotten a lot better, and her kidney function reflects the great job that was done. But what we can likely assume at this point is that she is inotrope dependent. Likely, what the team has done is said, wow, we've gotten her filling pressure so good. Let's inch off on the milrinone. And what happens as you inch off on the milrinone? The urine output goes down, the filling pressures go up, and the kidney function gets worse. And then you say, okay, now we have an inotrope dependent patient. We have met the criteria of the first essential question of the heart transplant evaluation: is the heart sick enough? The second question, which is equally as important, is the rest of the body well enough? So when I explain this to patients, I tell them exactly this. I say the purpose of the heart transplant evaluation is to document that your heart is sick enough and the rest of your body is well enough. How do we do that? Well, there's this standard approach, which is, of course, looking through the factors on the I need help mnemonics, the CPX, and the right heart catheterization to determine, is the heart sick enough, despite all attempts to exhaust optimization of therapy with the pillars of GDMT, as well as CRT when indicated, mitral valve TEER when indicated. Is the rest of the body well enough? Well, there's a standard approach that every patient will go through: scans, imaging tests, blood tests, meetings with specialists as part of the consultant team to determine the health of their kidneys, livers, lungs, gastrointestinal tract, vasculature, diabetes, thyroid function, any cancer histories, the standard health maintenance, and beyond. They will meet with the surgeon, the psychiatrist, the social worker, the pharmacist, the nutritionist, which is so important, this multidisciplinary collaboration to answer those questions. And what's wonderful about being a heart transplant cardiologist is you get to think about every organ system. And I always say, you don't have to know all the right answers, but you gotta know where to find them. So let's take, for example, a patient with significant extra cardiac disease. How do you figure out if their extra cardiac disease will impact their transplant candidacy? In other words, how do you make the consultant work for you? Well, you ask them very specific questions. Number one, will this extra cardiac condition affect their post-transplant survival, particularly in the context of immunosuppression? Our threshold is typically that the other condition must carry a prognosis such that they have a greater than 70% survival at 5 years and 50% survival at 10 years, which is essentially post-transplant survival. So if another condition is going to kill them sooner, mid-transplant is not the right approach. The second question is, will this extra cardiac condition impact their ability to rehabilitate post-transplant or impact their quality of life? For example, severe, diffuse, unrevascularizable peripheral vascular disease, which is such disabling claudication that a transplant won't improve them. Such severe lung disease from, say, COPD that they will still be horribly short of breath. These are the things we think about. And finally, is immunosuppression safe, effective, appropriate in the context of their extra cardiac disease? For something like a lupus or a sarcoid, it's very convenient because it'll treat both. For something like HIV, assuming there's an undetectable viral load, no opportunistic infections, acceptable CD4 count, is there stable antiretroviral regimen okay to give with immunosuppression? So it's all about asking the right questions to the consultants to get those answers.
Thank you so much. I think that's just a fantastic way of the way that we assess our patients, both from a cardiac perspective as well as an extracardiac perspective, and really the factors that come into this delicate interplay of who do we think is really going to benefit, not just from advanced therapies, but specifically from heart transplantation. Can you speak a little bit about your approach from evaluating someone in the outpatient setting as compared to the inpatient setting?
Absolutely. So the figuring out if the heart is sick enough in the outpatient versus inpatient setting is essentially the same. If they come to you as an outpatient, you'll run through your I need help mnemonic criteria, or are they looking like they're slipping into advanced heart failure? And you'll often have a CPX cardiopulmonary exercise stress test to confirm objectively their decreased functional capacity and poor prognosis. If they happen to be an inpatient, they're going to have at least a few of those I need help criteria to begin with because they are an inpatient. So you'll skip the CPX, but both inpatients and outpatients will get the right heart catheterization. Hugely important. One, to confirm how decompensated they are. Two, to assess for any potentially prohibitive pulmonary hypertension that will need to be optimized prior to listing. And three, is the cardiac index low enough to warrant inotropic support? So an outpatient evaluation may take a little bit longer, consultant scans and blood tests, but the testing is the same for both.
Dr. Kittleson, thank you so much. I love getting to hear you talk about that because I tell everybody that advanced therapies is really a team sport, and I feel like you highlighted that so well. So thank you. In summary, we have a 54-year-old woman with advanced cardiomyopathy that has been refractory to medical and resynchronization therapy with multiple hospitalizations over the past year, who now presents for expedited advanced therapies evaluation and management of associated cardiorenal syndrome. When discussing optimal treatment for her or for another patient, what are the factors that lead you to recommend durable LVAD as opposed to heart transplantation? And how do you counsel your patients on life with either LVAD or following heart transplant?
Wow, that's the million-dollar question. Reason number 7,042 while advanced heart failure transplant cardiology is the coolest field because we get to try to predict the future. I predict that you will have improved quality of life and survival with an advanced intervention, and I will use my extraordinary skills of communication to build trust and lead you through the process. It's so amazing. What a privilege. So when we think about LVAD versus transplant, we are now seeing with the HeartMate 3 studies that the 1 and 2 year survival of an LVAD can be comparable, in some cases better than heart transplantation. But it comes truly down to patient selection, and it comes down to the reality of the new allocation system where your wait time on inotropic support or temporary mechanical support will prioritize and decrease your time on the wait list far more than a stable LVAD. So I think it's likely cultural, different at different centers, depending on the center's expertise in transplant versus LVAD, as well as their experience with waitlist times inpatient versus outpatient. So our approach in general is that a patient will be listed for transplant, outpatient or inpatient as the case may be. And if they meet criteria for inpatient listing, we will always start with the inotropic support for status 3 listing. And if they fail inotrope, either because they're sliding from intermax 3 to 2, or because they have horrible ventricular arrhythmias that contraindicate inotropic support, then maybe temporary MCS, and give them a shot with any tweaking of sliding to a worsening intermax class to swoop in and do the LVAD. So how do you counsel patients on that? Because I try to be very honest with them. I say, listen, I get it. Transplant in 2025 is the holy grail. It is the gold standard, the established standard of optimal quality of life and survival for a patient with advanced heart failure. LVADs have come a long way, but there is a driveline, there is a power source, there is a level of care involved that is greater and distinct from that of a transplant. So while an LVAD is a miracle and a gift of life, and we're so lucky it exists, we understand that by and large, the priority of many patients is transplant, and the shortest distance between 2 points is a straight line, so people want to go straight to transplant. So this is what I tell my patients. Let's assume they've been through the evaluation, heart is sick enough, rest of the body's well enough. I will say transplant is the right option for you, and let's keep our fingers crossed that you have a boring wait to get there, whether it's a boring wait as an outpatient or a boring wait as an inpatient. But if you start to slide, and we, in our experience of predicting the future, are concerned that you are now on borrowed time, and the unpredictable and uncertain wait for transplant is not working in your favor, and we are concerned that this magical window of heart sick enough and rest of the body well enough is closing because of end organ dysfunction that is occurring during this wait time, we will tell you when the LVAD is the right time. You might not feel it's the case because you don't feel that different, but we are following so many parameters so very closely that we can help you decide that the ultimate goal is to get you healthy home and living your life, which is the right approach to get you there. So that's the overall philosophy is transplant. But when things start to slide and we can tell they're heading in the wrong direction, the window hasn't closed, but it is closing. That's the time to place the LVAD.
Thanks so much, Dr. Kittleson. I think it's really incredible to hear your own philosophy and viewpoints and your approach to patient selection and which patients to be referred for either durable LVAD or transplantation. Yeah, I'd love to hear just your opinions and get your input on some of the discussions that have been happening, especially in the advanced heart failure world, both with regards to the upcoming debate about status changes, about people that have been on durable LVADs for several years, about where they are on the wait list, as well as maybe changing over to a points-based system, the way that the liver allocation system is, and then also just your philosophy on, for young patients, being referred directly for transplantation first, knowing that median life expectancy is around 15 years versus going for durable LVAD first and then transplanting off a stable LVAD platform.
Wow, you saved all the hard questions for the end. Okay, this is good. So let's talk about the allocation system. I think whenever there's always good intentions and there are unintended consequences. So all of us want to do right by the patient sitting in front of us. And we also want to do right by the community of patients awaiting these scarce and precious organs. Honestly, I don't know what to think about a point system. My concern is that a point system creates a perception of accuracy and precision where one does not exist. The goal is to reduce wait time and waitlist mortality. We see that happen with this system that was put in place in 2018 with some unintended consequences of longer waits for some groups than others and more use of temporary MCS. So I'm remaining agnostic, open-minded, and doing my best to serve the patient in front of me while not forgetting the other patients. And to that, I mean always being conscious to ask myself, does this patient truly meet inpatient criteria? Number one. Number two, if they do, have they failed inotropic support as status 3 before I put in temporary MCS to make them status 2? That's my internal compass to follow not just the letter and the spirit of the allocation system. So I feel that always the sickest patients I'm sending to transplant. But I don't fault anyone for advocating for the patient in front of them because what we do is a privilege, but we see triumphs, but we also see tragedies, and we do our best to avoid them. For your next question about the LVAD and the younger patient, it's a great question. No one's ever going to do a randomized trial. And you know what? It's even having a large observational analysis is going to be impossible. There are so many unpredictable possibilities. Am I going to put an LVAD in this really lovely young person, but then they need 100 blood transfusions and now they're so sensitized that transplant's a problem? And when I do an LVAD, but oh gosh, they got this horrible stroke out of nowhere that no one was ever anticipating. Am I going to do an LVAD? And you know what? This driveline infection has turned into such a disaster that what's going to happen next? So I think it's very hard to withhold the standard care therapy of a transplant in an otherwise stable transplant candidate where the two options are equally weighed medically. I fully accept that there will likely be a diversity of opinions as you continue this series. Maybe you'll have debates at some point. But I would say the right answer is what works, and the right answer is shared decision-making. Now, I'm a big believer that shared decision-making is not abdication of medical opinion. You still have an opinion. However, you share the options with the patient. So I would guide the patient towards transplant, but lay out these options for them and help them figure out their priorities and goals and preferences.
Thanks so much. I think the big debate will be whenever we have, or we think that we have equipoise between durable LVAD and transplantation, what those conversations will be like and when we'll reach that point.
Yes, no, I agree. I think when we have fully implantable VADs and they don't cause any stroke, that will be a different conversation than the conversations we have now.
Thanks so much. It's always fantastic just to hear your viewpoint, your philosophy, your approach to all these patients and these really challenging questions that do come up both in our day-to-day lives and in clinical practice. We've covered a lot of topics tonight, but Dr. Kittleson, what would you say your main takeaways are for the CardioNerds?
Okay, number one, do your best to prevent a patient from ever needing a heart transplant. by assessing for underlying causes for which they made disease-directed therapies like sarcoidosis or amyloidosis. Number 2, optimize your guideline-directed medical therapy with CRT and MVTIR as appropriate. But if the patient meets those criteria, I need help, don't delay. Remember the magical window of their heart is sick enough and the rest of them is still well enough, and pounce on that evaluation so that you can get the patient to the therapy they need to give them good quality of life and survival, predicting the future based on the questions, is their heart sick enough and is the rest of their body well enough?
Thank you so much, Dr. Kittleson. I think this case really highlights all the intricacies and some of the challenges that we as advanced heart failure providers face. And I think more in a general sense, it provides a little bit of an overview of when general cardiologists and as well as internists should maybe refer to advanced heart failure. I know all of us here are very excited about this field, but I'd just like to ask you, what makes your heart flutter the most about the future of advanced heart failure and transplantation?
It's such a privilege to be part of a field where you can see patients at their best and at their worst and be a pivotal part of that process. I'm so excited about advances in the future, including things like donation after circulatory death, which has expanded our donor pool. I'm excited about novel ways, non-invasive diagnosis of rejection, novel immunomodulatory agents we can use to treat and prevent rejection, and these advances in LVAD that may someday lead to equipoise with heart transplantation. But at the end of the day, it is such a privilege to sit across from a patient and help them have the medical expertise to guide them through these life-changing decisions. It never gets old.
Dr. Kittleson, it has been our privilege to have you on this today for our inaugural Advanced Therapies episode for this series. Shazli and Jason, also thank you so much. CardioNerds, we hope that this got you excited to hear the remaining of our 6 episodes of 7. We're going to talk a lot about transplant. We're going to talk a lot about LVAD. We're going to talk about how palliative care fits into all of it, all of the time. So thank you so much for joining us. Dr. Kittleson, Shazli, and Jason, thank you so much for your time tonight.
Thanks, it was fun.
Thank you.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marquez. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.